Many times we give heparin injections in pregnancy. Heparins are blood thinner injections. Why do we give heparins in pregnancy? What are the indications of heparin in pregnancy? Is giving heparin in pregnancy having any harm? Are there any side effects? Why, when, how of heparin in pregnancy? Let's discuss all this. Good morning, I am Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. The question arises, why do we need to give heparin in pregnancy? Before I answer this question as to why the heparin is required in pregnancy, first of all, let us understand pregnancy is a hypercoagulable state. It is a procoagulant state. By meaning hypercoagulable, I mean that there are increase in coagulation factors in pregnancy and there are less anticoagulant factors in pregnancy. And this procoagulant effect increases throughout the pregnancy and it reaches the crescendo at the time of delivery. Now, some of you might be wondering why it is so. Basically, God has made this mechanism to control the amount of bleeding which occurs at the time of delivery. The amount of normal bleeding which occurs in a normal delivery, normal vaginal delivery, is about 500 to 700 ml, and during C-section it is about 1000 to 1500 ml. To control, to arrest that bleeding so that the patient does not go into postpartum hemorrhage, there is a natural procoagulant effect in pregnancy. And this predisposes pregnancy to the risk of venous thromboembolism or thrombosis in pregnancy. When we were in second year pathology, we were studying there is a triad called as a Workhorse triad, in which there is a hypercoagulable state, there is a venous stasis, and there is an injury to the vessels, which all the factors are effectively present in pregnancy. Venous stasis is because of the pressure of gravid uterus on the big iliac veins. External, the injury to the vessels wall occurs during delivery, and like I mentioned, procoagulant state is also always there. So any pregnancy is at a high risk of venous thromboembolism, and on top of that, there are various predisposing factors like increase in age, like obesity, IVF conceived pregnancy, blood pressure in pregnancy, immobility, cigarette smoking, multiple pregnancies. All these factors, they add up to the risk of thromboembolism or venous thromboembolism. And for prevention and treatment of venous thromboembolism in pregnancy, my friends, we give heparin in pregnancy. It is a definite risk. Heparin is a very, very important molecule in pregnancy. Because there is an early activation of the coagulation cascade, the procoagulant effect increases. We have to start heparin as soon as pregnancy is diagnosed in patients who are at high risk of venous thromboembolism. This procoagulant effect of pregnancy is also responsible for something called as GVC. GVC is gestational vascular complications. Now, what are these gestational vascular complications? All the patients who in previous pregnancy have had preeclampsia, that means high blood pressure, previous intrauterine fetal death, stillbirth, previous antepartum hemorrhage, abruptio placentae, previous fetal growth restriction, previous early pregnancy loss, late and early recurrent miscarriages, they all are classified as gestational vascular complications. These are because of placental thrombosis or because of placental ischemia. If it is placental thrombosis, then it leads to the early pregnancy loss, and if it is placental ischemia, it leads to late and early fetal growth restriction and preeclampsia. Although the use of heparins in gestational vascular complications is not supported by hard evidence, but all practicalities and all the studies, they too suggest that heparins have got a definite role in prevention and management of gestational vascular complications. Still, if there is a thrombotic factor clustering, like I told, older age, long years of infertility, multiple pregnancy, previous multiple sections, IVF pregnancies, heparin would add much value to that pregnancy in prevention and the treatment of gestational vascular complications both. Now, whether any pregnancy is at risk of thrombosis or not, I mentioned the predisposing factors, I mentioned the aggravating factors, but there is an online calculator, that is a PAT, pregnancy associated thrombotic risk, and it can be assessed online at www.patrisk.com. It is a calculus which calculates the risk of pregnancy, and everybody can calculate her own risk of thrombosis in pregnancy by putting the denominators. So To prevent the thrombosis, low-dose aspirin is given in almost all the pregnancies. I have made a video on low-dose aspirin. Please go and have a look at it. By low-dose aspirin, I mean 75 milligram to 150 milligram. Earlier, they used to say less than 50 kg patient body weight should be given 75 milligram aspirin, and more than 50 kg should be given 100 or 150 milligram aspirin. But recent Cochrane data says that irrespective of the weight, you should give 150 milligram aspirin in all the patients who are at high risk of gestational vascular complications. There is an increasing, apart from the use of heparins in venous thromboembolism, thromboprophylaxis, in early pregnancy loss, in gestational vascular complications, aspirin has also been used in the IVF, in assisted reproductive therapy. Heparin, it aids in implantation, it aids in the blastocyst apposition, it increases the endometrial receptivity, it increases the trophoblast invasion, and it helps in IVF. According to RCOG, IVF is a transient risk factor for thromboembolism, and it increases the risk factor of venous thromboembolism by a factor of 4, and it increases the risk of pulmonary embolism by a factor of 7. So, the use of heparin, preferably low molecular weight heparin, is not only used in the venous thromboembolism prophylaxis and management, but it is also used for the prevention and treatment of gestational vascular complications. It is also used for the optimization of IVF pregnancies. Healthy pregnancy needs a healthy uteroplacental circulation. The suitable development and implantation of pregnancy is based on the development and conservation of a absolutely normal uteroplacental circulation. And a defective placental function as a result of placental ischemia or placental thrombosis may lead to early pregnancy loss or fetal growth restriction, and that is where the heparin or a low molecular weight heparin plays a very, very important role. Also, in cases of immunological factors in which hereditary and acquired thrombophilia play a role, they cause placental clot, they cause platelet aggregation, coagulation, and thereby leading to an early pregnancy loss and possibility of severe preeclampsia or fetal growth restriction later on in the pregnancy. In those cases, heparin is a very, very important factor. In hereditary thrombophilias, especially in our part of the world, in Asia, in protein S and protein C deficiencies are more common, whereas in the Western world, factor V Leiden deficiency and prothrombin mutation are very, very common. In most of the cases of unexplained pregnancy loss, we as doctors know only few cases of known causes of recurrent pregnancy loss or a pregnancy loss. But if in most of the cases in recurrent pregnancy loss, if the cause cannot be found out, if we have ruled out the chromosomal anomalies, if we have ruled out the uterine anomalies, if we have ruled out the endocrine anomalies, then most likely cause is placental thrombosis. And in cases of unexplained recurrent pregnancy loss, again, like I mentioned, heparin plays a very, very important role in continuation and management of gestational vascular complications. So, apart from the benefits on a coagulation cascade, low molecular weight heparin, it helps in managing the gestational vascular complications. It decreases the inflammation, it inhibits the complement activation, it increases the proteases involving trophoblast invasion, and thereby helps in implantation of an blastocyst. Thereby it helps in IVF, not only improving the results of IVF, improving the results of implantation, and also it improves the chances of a THBR, that is take home baby rate. It increases the incidence of live birth. So the question comes, what type of heparin do we use in either the management of recurrent pregnancy loss or gestational vascular complications or fetal growth restrictions or thromboprophylaxis? The best, the gold standard heparin nowadays is LMWH, that is called as low molecular weight heparin. The advantage of low molecular weight heparin, it comes within PFS, pre-filled syringe. The advantage of low molecular weight heparin is that it does not require an extensive monitoring, and it has an improved safety profile and relatively less side effects of thrombocytopenia and osteopenia. The problem is it is relatively expensive. It comes in doses of 0.2, 0.4 and 0.6. It is a relatively expensive drug. It has got problems with, in emergency, if you have to give a spinal or epidural analgesia, then there has to be a dosage withholding of at least 12 to 16 hours. Compared to that, earlier on we were using unfractionated heparin. Unfractionated heparin is short acting. There can be problems related to osteopenia, heparin-induced thrombocytopenia. There can be an episodes of bleeding. If patient does not have financial issues, then LMWH is best. It is given on abdomen, subcutaneous. It is just given like a pen. It can be given. And it is absolutely safe. Usually no monitoring is required. Maybe a partial thromboplasting time can be done. Factor 10A levels are usually not required. What are the side effects of giving heparin in pregnancy? Most of the patients are worried, sir, it is a blood thinner injection, so I'll have increased episodes of bleeding. Suppose I happen to have a cut, then my bleeding would be more. Answer is no. Yes, the bleeding time and clotting time would increase slightly, but bleeding would not stop only. There are episodes of CRNM, clinically relevant non-major bleeding. They can be in form of epistaxis, they can be in form of vaginal spotting. Usually most of them are self-limited. They do not require the dose adjustment, and a simple pressure or temporary withholding of drug, 1 or 2 drugs, can take care of all these bleedings. Osteopenia is a definite side effect in which vitamin D and calcium deficiency are there for if heparin is given for long, especially in unfractionated heparin. That can be taken care of by calcium and vitamin D supplementation. Normally we give calcium vitamin D tablets twice daily for at least 1 to 2 years continuously, even after we have stopped the use of heparin. It is relatively less with the low molecular weight heparin. And last, HIT, it is called as heparin induced thrombocytopenia. Some people fear that heparin might lead to the decrease in platelet counts, but in most of the cases heparin acts on coagulation factor, it does not act on platelets. So chances of heparin induced thrombocytopenia are almost negligible with low molecular weight heparin. However, in unfractionated heparin, it might be the case in few cases, but those are not very complicated. The advantages of giving heparin in such cases outweigh such kind of minor disadvantages. So in conclusion, LMWH or unfractionated heparin, they are very, very useful in management of thromboprophylaxis in pregnancy, in management of venous thromboembolism in pregnancy. They are also useful in, although there is no hard evidence, but they prolong the pregnancy in gestational vascular complications like preeclampsia, fetal growth restrictions, previous IOFD, stillbirth, previous early pregnancy loss. What I do is, if a case of a gestational vascular complication is there and there is a previous history, at 24 weeks of ultrasound, if there is a high uterine artery resistance, again I am telling, if normally in most of the cases uterine artery resistance becomes normal by 24 weeks, there is a disappearance of a diastolic notch. If there is a persistence of a diastolic notch or there is a increase in uterine artery resistance at 24 weeks, then I start usually heparin in those cases along with L-arginine and sildenafil. All these things, they act at different side pathways. Sildenafil would act as a vasodilator, L-arginine would act as a vasodilator. It would act in improving the weight of the baby, and heparin would improve the blood flow to the baby, thereby taking care of a possible preeclampsia, possible fetal growth restriction, possible preventing a possible abruptio placentae later on in the pregnancy, and it increases the chances of pregnancy. Same is the case with optimization of IVF pregnancies. First of all, if there are multiple recurrent IVF failures, if there are multiple IVF pregnancies followed by miscarriages or history of recurrent pregnancy loss in which the cause is not found, the moment we transfer an embryo, we start heparin, low molecular weight heparin, or the moment the pregnancy test is positive, we start low molecular weight heparin. We have to continue, if we are giving a prophylaxis dose, we have to continue once daily, almost till the delivery. We need to stop the day before delivery. If we are giving low molecular weight heparin and cost is a factor, after 36 weeks, we can switch over to unfractionated heparin. Because unfractionated heparin are short acting, they do not need much reversal time, and if the patient goes into labor, the effect of low molecular weight heparin can be reversed by an injection called as protamine sulfate. But those cases are very few and far between. The advantages of heparin, they far outweigh the disadvantages whatever the heparin might be causing. I very routinely and very frequently am using heparin in my practice, and it gives me a very, very good result. Only thing is, patient has to take calcium continuously for at least 2 years, 3 years after the stoppage of heparin. Anyway, after delivery we have to take calcium, so for 1 year. So calcium vitamin D combination has to be continued for at least 2 years, 3 years after the stoppage of heparin. Hope you like this video. Please subscribe to our channel and please share the video. Thank you. Bye bye.